So I think we all know hip pathology is increasingly recognized in our adolescent population. Regarding femoral acetabular impingement, we ask, how did we get there? What is the etiology? And a lot of that work's been done right here in Bern. So here are a number of studies that have looked at femoral physeal development and the relationship to athletic activity, and Professor Siebenrock has kind of led the way with regards to this. Recent literature has reported outcomes in adolescents after arthroscopic FAI corrective surgery, but there's really very limited information in the setting of open physes. The majority of these patients in the previous studies, it either wasn't mentioned or that physes were closed. So our purpose was to evaluate arthroscopic FAI corrective surgery in a cohort of adolescent athletes with open physes to assess plane radiographs, patient-related outcome measures, return to athletics and complications, and to describe the three-dimensional pathomorphology. This is a retrospective review of 37 hips. All of these patients had open growth plates, arthroscopic FAI surgery by one surgeon. All patients underwent preoperative, postoperative AP pelvis 45-degree done lateral radiographs. Lateral center edge angle was looked at, acetabular inclination, alpha angle, head neck offset ratio. These were all done on the plane radiographs. I didn't say before, but I should also thank Jeff Neppel, Jim Ross, and Ashish Beatty for all their hard work with this as well. So when we look at the PHYSIS assessment, we looked at the femoral physis, iliac apophysis, triradiate cartilage, greater trochanteric apophysis, and the ischiotuberosity apophysis. In addition, at the suggestion of Jeff Neppel, we'll give him credit for this, we also looked at Oxford bone age. So we know chronologic age may not reflect skeletal maturity. So we looked at Oxford bone age to allow for assessment of physiologic maturity, with those numbers below showing whether somebody is very immature, immature, or nearly mature. And that's from the SCIFI data. So each patient underwent a high-resolution CT scan of the involved hip. Preoperative CT was also uploaded into a dynamic software program used to generate patient-specific 3D models of the hip joint. And then virtual radiographs were also pulled from that for 2D measurements from the CT scans. So we looked at proximal femoral morphology, femoral version, neck shaft angle, alpha angles, maximum alpha angle and location. We also looked at acetabular version, CT-based lateral center edge angle, and the presence or absence of a crossover sign, posterior wall sign, or prominent ischial spine sign. Surgical treatment was essentially a minimal acetabular rim resection in nearly all cases. A labral refixation was performed for any acetabular overcoverage and labral tearing. The anterior inferior iliac spine was decompressed when there was any deformity involving the subspine region. The femoral physis was not spared during the CAM osteoplasty with the goal of being correction of femoral asphericity and offset. So here's just a video example. So this is after the labral repair has been done. You can see the cam deformity. This is a right hip. You can see the limited range of motion. The capsulotomy is done. So once you're removing the soft tissue, the cartilage, the periosteum, you'll start to make out the growth plate. And then as we go further, you can make out the entire growth plate. Initially, here we'll show the anterior physis on the femur. And then as we come more lateral, which we've talked about in the studies, you can see how that lateral portion really extends distal, as Professor Siebenrock has talked about, secondary to athletic activity in a number of individuals. And early on, I did not do any physeal ablation, but I did have a couple of patients who had some recurrence at the physis. So since then, I've done an ablation with a thermal device across the entire anterolateral physis. And then once I finish with the ablation, we would then close the capsule and then perform our dynamic assessment to make sure that we have improved range of motion in a number of different positions and no evidence for impingement. So pre- and post-operative function were evaluated with the modified Harris hip score, SF12 scoring, and VAS scoring. Post-operative radiographs were looked at for recurrence and growth arrest. Here's just an example of a 12-year-old male. You can see the preoperative radiographs at the left, very mild, decreased head neck offset. 2-week radiographs after the femoral section. And then at 3 years, you can see the growth plate's actually still open on the femoral side, and there's really been no obvious evidence for growth arrest, and the femoral section still looks good. We'd obviously need three-dimensional imaging to better evaluate any potential low-grade deformity, but we did not get repeat CT scans in these individuals. So the mean age was 15. The majority of these were males. When we looked at our radiographic evaluation of open physis, 100% had an open femoral neck physis and iliac apophysis, 95% had an open greater trochanter, 54% ischial tuberosity was still open, and 3% triradiate cartilage was open. Here's the Oxford bone age. So there's variable maturity among the males, while all females were really approaching maturity. In the 14 to 15-year-old male group, some were very mature, some immature, and some nearly mature. But I think this is representative of our younger patients with typical femoroacetabular impingement. Plain radiographs, the lateral center edge angle was a mean 30, the mean tonus angle was 4.5, and there was a significant reduction in the alpha angle on the AP and lateral view after surgery, and an improvement in our head-neck offset ratio. If we look at the CT measurements, our femoral neck shaft was 133 on average. Femoral version was a mean 17.6, with a small number being less than 5 and 14% being greater than 25. If we look at our alpha angles, the majority of the cam deformity, as previously described, was between 12:15 and 3 o'clock for a right hip, with the maximum mean alpha angle of 72 at max alpha angle location of 115, which is typical with previous studies. Acetabular version at 130 was a mean 1 degrees, at 3 o'clock mean 14. There were 7.4, just 2 patients, 7.4%, that had a lateral center edge angle within that very mildly dysplastic or borderline group. There was a positive crossover sign and positive posterior wall sign in a significant number of these individuals, but none had a positive ischial spine sign. So result-wise, all cases had femoral and/or acetabular correction for FAI. Over 90% underwent a cam osteoplasty, minimal acetabuloplasty in general, and also labral refixation, and about a third had a subspine decompression. There were no clinically or radiographic documented growth disturbances, physeal rest, or AVN. 2 hips with subsequent surgery. They had a redevelopment of a cam-type pathomorphology at the edge of the growth plate, the physis, and that was prior to performing any physeal thermal ablation early on. Mean follow-up was 30.6 months. Modified Harris hip score improved, 25 points. These patients generally do great. They're young athletic patients, and they do very well. The VAS decreased. The SF12 was improved significantly as well. 2 hips were failures with a modified Harris hip of less than 70. And if you look at their mean latest modified Harris hip, it was 94. So it's very high, but very typical for this young population. If we look at multivariate analysis, if they had a greater pre-op lateral center edge angle, they had a greater change in their modified Harris hip score, and a greater preoperative AP alpha angle had a greater change in their VAS score. 93%, which you would expect at least, returned to pre-injury level of sports, which included basketball, ice hockey, track and field, football, softball, and wrestling. So discussion. Again, Professor Siebenrock has performed a number of studies, this one looking at 72 hips in elite male basketball players and a control group of asymptomatic individuals who did not participate in high-level sports, showing a 10 times risk of the non-athletes, a 10 times risk greater than the non-athletes to develop a cam deformity. This is a systematic review that Jeff Neppel and John Closey performed, looking at 9 articles, again showing that high-level male athletes are 1.9 to 8 times more likely to develop a cam deformity than controls, so better understanding at least the femoral side in response to vigorous activity. This systematic review was done in 2015, looking at adolescent and skeletally immature individuals. Although there were 435 hips in this study, really a number of them were not documented whether the growth plates were open and which ones were, and the majority of these were just listed as adolescents. But 80 to 100% satisfaction, improved outcomes, and a high return to sports. So in conclusion, FAI corrective procedures performed in symptomatic patients with partially or completely open growth plates had improved outcomes at short-term follow-up, no radiographic or clinical evidence for growth disturbance. An osseous decompression with an anterolateral femoral physeal ablation at this stage of development appears to be safe without a need to avoid the physis on the femoral side. Certainly further studies are required to better define the long-term outcome and risks of open or arthroscopic procedures in skeletally immature individuals. But I think in the end, the majority of these individuals will likely be nearing skeletal maturity and are really at a low risk for complications. Thank you very much.